I want to present to you a session on thresholds and rating the certainty of evidence using grade, and how this integrates specifically into Cochrane systematic reviews, and how thresholds or decision thresholds help us in both rating the certainty of the evidence and communicating the findings of our systematic reviews. So just as a quick introduction, thanks so much, June, for the overview of my general role. I'll just add for today, I don't have any specific conflicts of interest related to this presentation, or in particular financial conflicts. I have published on this work as part of the grade working group project group on decision thresholds as part of the evidence decision frameworks. And I also want to acknowledge Dr. Ignacio Newman for contributing some of the slides and graphics that I will present to you today. And as part of our webinar, there are going to be three main objectives I'd like to cover, which is rating the certainty of evidence by incorporating thresholds, reviewing the grade guidance on setting decision thresholds for the magnitude of effects, how we can practically do this for our systematic reviews, and conclude with using and presenting the thresholds in systematic reviews and how this can look like in Cochrane reviews specifically. The information I'll present today is covered and based off of the grade book, which is the resource for the grade working group guidance on each of the aspects for rating the certainty of evidence, as well as going from evidence decisions specifically for guidelines, and it's available at book.gradepro.org. Likewise, the content I'll cover today is covered in grade guidance number 42, which was published last year, which covers using decision thresholds for judgments about the health benefits and harms, which is the topic for today. Let's start with the first section on rating certainty of evidence by incorporating thresholds. So for this, we need to revisit, which for those of you who have joined the first webinar, the certainty of evidence rating using the grade approach. For the operational definition for certainty of the evidence, what we mean is our confidence that the true value of an estimate falls within a specific range or above or below a specific threshold. So here you have the visual demonstration. When we are deciding about our confidence that the true value of an estimated effect falls within a specific range or above or below a relevant threshold, there are two aspects we are deciding on. One are those decision thresholds. So these are reference values for decision making, and in the context of our systematic reviews, in the context of grade and making decisions about health benefits and health harms, this is, for example, the threshold of what we would consider a trivial to a small effect. So where do we go from the decision about an effect being trivial to that being a small effect? We need to choose our target of the certainty rating. So what is it that we are assessing our certainty in? And for example, that would be the moderate effect range, that the true value of the estimate falls within the moderate effect range. In terms of the certainty of evidence and within the grade approach, there are various types of evidence. Intervention studies, evidence on patients' values or relative importance of outcomes, on diagnostic test accuracy, for example, on prognostic studies, so covering association between predictors and outcomes, or for example, evidence on environmental health, where we're looking at relationship between exposures and outcomes. For the purpose of today's webinar, we are focusing on the certainty of evidence from intervention studies, so that being treatment effects. And here, to illustrate graphically, if we consider what is our target of the certainty rating, so for example, moderate benefit. If we have multiple studies included in our systematic review, each with their own effect estimate for a given outcome and 95% confidence interval, our target for the certainty rating that being a moderate benefit, is that as suggested by the location of the pooled estimate relative to the thresholds of interest. So here graphically, you can see, for example, we are concerned whether the estimate of the effect the true value of the estimate of the effect lies within a particular range, and that being here, that of a moderate benefit. And here are other thresholds for going from a trivial to a small benefit, a small to a moderate benefit, and a moderate to a large benefit. And likewise, we have the same thresholds on the harm side for going from a trivial to small harm, small to moderate, moderate to large. So for our reviews, while this forest plot figure looks familiar to us, what do we mean? So for example, when we are thinking about the target for a certainty rating, that is about our pooled estimate relative to the thresholds. So here we have an example of an evidence profile or summary of findings table that we would see typically in a Cochrane review, where here it's an example from the topic of multi-drug resistant tuberculosis, and it's comparing the risk of adverse events with a currently recommended standard treatment to a new combination treatment. And here we have for adverse events our relative effect of 0.90 and the associated 95% confidence interval. And we have our absolute effect here, which is 38 fewer adverse events per 1,000 with the new combination treatment, as compared to the currently recommended combination treatment. So here's an example of our pooled effect estimate using a relative risk and absolute effect per 1,000 people. Likewise, we can have our pooled estimate be for a continuous outcome. So here, our target may be determining whether the true value of the effect lies within that range of a trivial or not important effect. For example, for the outcome of weight change, which is measured as a mean difference in terms of kilograms and has the associated 95% confidence interval. So the thresholds are, and the relation of the effect to the threshold is all to do with our pooled effect from a systematic review in relation to the thresholds that we set for what is a trivial, small, moderate, or large effect in terms of benefits or harms. So in grade, we have the 4 levels of certainty. We have high, moderate, low, and very low, which we arrive at by assessing the grade domains of risk of bias or study limitations, limitations in study reporting or execution, imprecision, inconsistency, indirectness, and publication or dissemination bias. And with these ratings, what do we mean again by high certainty? So by high certainty, we have high confidence that the true value of the estimate of interest for the given outcome is at one side of a threshold of interest or within a specific range. So here, for example, we were talking about the target of the certainty rating being that of a moderate benefit. Then, when we have concerns about the certainty of the evidence, and we may rate down the certainty to moderate, what this means is that the true value of the estimate may deviate slightly from the target of the certainty rating. So it may actually, for example, fall within the range of a small benefit rather than the moderate benefit, which is our target certainty range. As an example here. Then if you think about low certainty, the true value of the estimate may deviate from the target of the certainty rating and likely fall in a completely different range. So for example, rather than being a moderate benefit, it may be a trivial or not important effect, the true value of the estimate. Likewise, for very low certainty, the true value of the estimate may deviate significantly from the target of the certainty rating, again, which was our moderate benefit, and it would probably fall in a different range. As an example here, it may actually be all the way over to a small harm. And again, this is in relation to each of our thresholds. Hopefully that gives a good overview and introduction to what we mean by thresholds and applying thresholds to rating the certainty of evidence using the grade approach. And here, as a refresher, the certainty assessment is a 4-step process. So one is determining the number of the thresholds, thinking about ranges and the estimated effect either being beyond a certain threshold, so setting 2 thresholds for benefit and harm, or a single threshold, or multiple thresholds for small, moderate, large benefits and harms. Then it is determining the target of the certainty, so whether it lies within a specific range or beyond a threshold. Then we evaluate the evidence by conducting our synthesis and meta-analysis, for example, in the systematic review, and determining whether to rate up or down our certainty. And again, here as a refresher, for the certainty of evidence assessment, we consider evidence from randomized studies, non-randomized studies. This is for treatment effects, considering starting at a rating of high with randomized studies and non-randomized studies as assessed by the Robbins I risk of bias tool. And then we consider each of the 5 domains for rating down the certainty of evidence. For non-randomized studies, we then consider as well, if there are no concerns, domains for rating up the certainty of evidence, where we land on one of our 4 certainty ratings. Here, you can start to see that the decision thresholds then have a large role in determining the certainty of evidence. For risk of bias, which is also referred to as limitations of study design, execution, and reporting. For indirectness, inconsistency, and precision, these will be covered in the upcoming Cochrane Learning Live grade webinars. So for today, we won't go into the detail of how we rate imprecision, for example, applying the decision thresholds, or how we rate inconsistency and indirectness. I'll show an illustrative example now, but the details of applying thresholds and applying grade to rate the certainty of evidence within each of these domains will be covered in the future webinars. But just as an example here, for illustration, if we're considering the domain of imprecision, we, according to the grade guidance, considered a number of thresholds crossed by the 95% confidence interval of our pooled effect. So here, for example, we see a pooled effect, a standardized mean difference of 0.34 lower for depressive symptoms with the 95% confidence interval from negative 0.85 to 0.17. And when you plot it out here, you see that this estimate of the effect and the 95% confidence interval crosses 3 thresholds, that going from a large benefit to a trivial or not important effect on the harm side. What's important here is that we don't use the line of no effect as the threshold. This entire range here is trivial or no important effects, so it covers trivial benefit and trivial harm. And here in this case, you could see that crossing 3 thresholds, we would make an assessment that there's extremely serious imprecision, and we would rate down by 3 levels. So you'll see many more examples in the upcoming webinars on each of the grade domains for rating the certainty of evidence. But for today, we want to cover how do we actually decide on the thresholds and apply them in our systematic reviews. How do we decide what is the threshold for going between a trivial effect to a small benefit, from a small to a moderate benefit, from a moderate benefit to a large benefit, and likewise our thresholds for each of the harms, small, moderate, large harms. What is the corresponding effect size that we would set as our thresholds to inform both our grade certainty of evidence rating, but determining what magnitude of effect does that pooled effect in our systematic review represent? Again, is it a small, moderate, large benefit, Is it trivial or no important effect, or is it a small, moderate, large harm for a given outcome? And what I'll cover next is that grade guidance on setting decision thresholds for magnitude of effects, which gives us some direction on what systematic reviewers may do to set the decision thresholds in their systematic review. And again, this is published as grade guidance number 42, available in the Annals of Internal Medicine with the DOI and reference available here. Furthermore, the grade guidance and one of the approaches that I'll present is based on a randomized methodological study that was conducted to inform the development of that grade guidance. And in this study, we are able to derive our decision thresholds based on research data. I'll give a few details about what this study provided us and how it was run to suggest generic coefficients that could be applied across different outcomes to suggest a threshold. What I want to note here at this time is this is specific to dichotomous outcomes. I'll also cover continuous outcomes as well as methods of measurements such as standardized mean difference. But the reference here is available for you to review for some additional details if you are interested, but I'll give a brief overview now. So in the grade guidance 42, we set two approaches to determine decision thresholds. One is deriving the decision thresholds for dichotomous outcomes based on the grade threshold study. And what this method considers is that the outcome-specific thresholds are determined through a calculation of generic coefficients, which we derived from this grade threshold study, and an outcomes utility value. So those coefficients were derived with case scenarios that were used in the grade threshold study and to which respondents representing typical decision makers in the context of a guideline development, for example, or users of a systematic review to determine what would be perceived as a small, moderate, trivial, small, moderate, large benefit or harm for that given case scenario. And the two assumptions here were that the judgments were driven by the size of the effect, so the absolute risk difference, and the outcomes disutility. So the outcome utility value is how we are able to generate these generic coefficients that can then apply across different types of outcomes. The second approach outlined in grade guidance 42 is deriving the decision thresholds based on expert input directly. And experts may be clinical experts, they may be patient representative experts in whatever decision-making context the review is for. So the outcome-specific decision thresholds are determined directly through methods such as surveying the decision makers to explicitly assign thresholds for the outcomes of interest. So again, what for a dichotomous outcome, what events, what number of events, fewer or more, per let's say 1,000 people, would be considered a small effect or a moderate effect, and that way we can set our thresholds. These two approaches can be used in combination with the calculations based on the research data and the generic coefficients. These could be confirmed through surveying decision makers to see if the calculations provided are in line with their perceived decision thresholds that they would set for a given outcome. So briefly, what the grade threshold study included were these case scenarios that included a summary of findings table, a description of the health outcome. Here, for example, we have major ischemic stroke as an outcome in one of the case scenarios, and the utility value for the outcome based on search of the literature reporting what the utility outcome, what the utility value would be for an outcome such as major ischemic stroke. And respondents were asked to select what they would consider the upper and lower bound for a small effect, a moderate effect, and then anything beyond a moderate effect was considered large. Anything below a small effect was considered trivial. And also to select based on this case scenario of 40 fewer major ischemic strokes, what was the their judgment for the effect size. Here it's a reduction, so it's a desirable effect. an example, maybe someone selects small. So here, respondents were randomized to 4 of 10 different case scenarios. And with this, we were able to generate the empirical data of what were typical trivial, small, moderate, large effects across these different case examples. And given that each of the outcomes had a utility value, we can generate a generic calculation, which is provided in Grade Guidance 42, for what could be considered a decision threshold, each of the decision thresholds for a given outcome. And maybe the best way to demonstrate this is showing the online calculator that was developed for applying the approach 1 using the research data-based approach. So here at this link, and I'll show it briefly on the browser as well, you are able to enter an outcome utility value, which provides then, based on the calculation against those generic coefficients derived from the grade threshold study, the decision thresholds for what would be considered a small, moderate, and large effect. So here as an example, we can enter 0.7 as a utility value, which generates for us the 3 decision thresholds. So 55 fewer or more events per 1,000 individuals for going from a trivial to a small effect, 136 events for going from a small to moderate effect, and 257 events fewer or more for going from a moderate to large effects. And here we assume that the thresholds for benefits and harms are symmetrical. And I'll briefly show what the calculator looks like online here. It's exactly as in the slides you just saw. Here, you select whether you're entering a utility or disutility value, which is 1 minus utility, and whether the increase of the outcome is desirable or undesirable to set the direction. Optionally, you could also include your absolute effect size, so your risk difference from your systematic review, your actual pooled effect. So here we see the suggested decision thresholds for an outcome with a utility value of 0.7, which is an undesirable outcome. When there is more of the outcome, we can, for example, include here, if there were 70 events, it would be considered small, as 70 is beyond the threshold of 55, which is the threshold for going from trivial to small effects. So this online calculator is handy to apply the research-based approach for setting decision thresholds. For setting decision thresholds directly from decision makers, approach 2, we can do this through survey methods, surveying decision makers to explicitly assign thresholds for the outcomes of interest. And there's also some other sources which we may look for decision thresholds. There may be existing published systematic reviews and guidelines, for example. As well here, as I mentioned, for continuous outcomes and patient-reported outcomes using scales, we typically have published minimally important difference, the MID, which we would consider equivalent to that small important effect, so the threshold between a trivial and a small effect. For outcomes assessed using a standardized mean difference, we have Cohen's criteria as suggested thresholds for what is a small, moderate, or large effect. So here with the group, I want to try an example of what you would consider. I can go over to the Menti here. What you would consider a threshold for a small important benefit of weight loss in kilograms. Would you consider 2 kilograms, 5 kilograms, 10 kilograms, or 20 kilograms as a threshold for a small important benefit or weight loss? I'll go back to the slides. You can either type in menti.com and put in the number here or use the QR code. Great, I'm seeing some responses come in. And I'll share with you the results here. So you see here as an interesting example, I would consider these fairly equivalent answers for, so 24 people from our group today considered that 2 kilograms of weight loss is a small important benefit, 32 considered 5 kilograms, and then fewer considered 10 and 20 kilograms. So you can consider this as an approach, for example, if you don't have published evidence, that in a survey of decision makers can help gauge what would be typically considered threshold for a small important benefit. You could also ask about moderate and large benefit in terms of weight loss. Now, for systematic reviewers, we may not often have access or ability to conduct one of these surveys that we may conduct typically as part of guideline development. One of the approaches then could be, for example, setting assumptions. If we have an example such as this, where, and this is from a Cochrane review example that I'll show later as well, where, for example, you may consider based on the control group event rate, what may be arbitrarily set thresholds for a 5% difference, 10% difference, or 20% difference, being our thresholds for small, moderate, and large effects. So for that example I showed of weight change at 12 months, mean difference of 1.07 kilograms less is in fact a trivial or not important effect. Likewise, as mentioned for Cohen's criteria, the suggested effect sizes are a standardized mean difference of 0.2, 0.5, and 0.8, which we could use for our thresholds for continuous outcomes measured or assessed using SMD. Here, an example of depressive symptoms. So based on the SMD here, we see that the effect goes from that large benefit, 0.85, so beyond 0.8, to a trivial or not important harm, 0.17, not reaching 0.2. A case example of what this looks like practically in a systematic review. One example of a guideline I worked on with the World Health Organization for the consolidated guidelines on drug-resistant tuberculosis, where we identified utility values from a literature search for priority outcomes for our systematic reviews and later for the guideline. And we also conducted a survey of the guideline development group to agree on the thresholds. So as an example of treatment failure or recurrence of tuberculosis, we had set the following thresholds of 30 or less for a trivial effect, 31 to 59 for a small effect, 60 to 119 for a moderate effect, and a large effect being 120 fewer or more events per 1,000 people. And again, this is setting these thresholds for absolute effects. So here we have a couple of different ways for setting the thresholds, couple of different ways to decide on setting thresholds for each of the magnitudes of effects or setting a single threshold, for example, for a minimally important difference or at least a small important effect, and then making our target for the certainty of evidence rating being that the true value of the estimate falls somewhere beyond that single threshold, or again, within a particular range with multiple thresholds. So how can we use these use and present the thresholds in systematic reviews? Here, a couple of examples would be presenting our estimates of the effects in a figure where we consider the estimates of the effects and the 95% confidence intervals for each of the outcomes on a figure similar to a forest plot, but on the x-axis here has our ranges of effects. So trivial or no effect, small, moderate, large benefit here. Here favoring the intervention, and here favoring the control with harms for the intervention of interest. And here we presented, for example, for the intervention of the new combined treatment regimen, an increase in failure and recurrence, trivial or no effect in death, a trivial or no effect or trivial benefit for loss to follow-up, a small benefit for adverse events, and a trivial benefit for amplification of drug resistance. This is one example of a figure that could be included within a systematic review for presenting the summary of the effect estimates and the 95% confidence intervals for those pooled effects in relation to the decision thresholds that are set. As part of the online calculator, there is an option at the top. There's the two tabs. We viewed the single outcome calculation using the utility values. And there's also a way to generate the figure that I just showed. The ones for the WHO example were graded manually, and then later the grade project working group presented the presented the guidance, developed this calculator and graphical presentation here. So here you can download a template for inserting each of the outcomes for a systematic review, inserting this utility, inserting the absolute risk difference from the meta-analysis, and then the 95% confidence intervals. And what this allows us is to generate a figure. Here I have two outcomes inserted as an example for upper respiratory tract infection and diarrhea, showing where the estimate of the effect lies with the 95% confidence interval in relation to the thresholds. Another example of how we can present the estimates of effects and apply the decision thresholds is that in forest plots. So here, integrating the thresholds into our forest plots would allow us to present the information graphically and also ensure that the readers will not always need to check back to the methods for what the decision thresholds we set for our certainty rating in the systematic review. So here I'll take us through an example where in the review, we assessed maternal intake of prebiotics to reduce allergies in children. And in the systematic review, there were 5 included trials. And we have our pooled estimate of the effect here, which was a risk ratio of 0.56, 95% confidence interval of 0.38 to 0.82. Taking us through the calculations, because we do consider the decision thresholds in relation to the absolute effects, but we can convert back to risk ratios as well and apply the decision thresholds in our forest plot. So here the necessary values are the risk ratio and our control group event rate. So 79 events out of 630 people. And what this gives us is our absolute effect estimate for this risk ratio and the control group event rate. So for 125 out of 1,000, which is 79 out of 630 people, is a risk of allergies with no prebiotics in this example. Risk ratio is 0.56. When we multiply 0.56 by 125, we get 70 people with allergies with prebiotics. And here our difference in the intervention group is 55 fewer. So 125 minus 70 equals 55. And then you apply the same for the lower and upper bound of the confidence interval. So this translates for 0.56 risk ratio, 95% confidence interval to be 55 fewer people out of 1,000. And the 95% confidence interval is 77 fewer, or 22 fewer to 77 fewer. I have that flipped around. Looking up what may be a typical utility value for individuals with food allergies, I just quickly found a article that reported 0.85 as a utility value. and putting this into our thresholds calculator for determining the decision thresholds based on the research data, we get 63 events, 157 events, and 295 events. So 6%, 15%, and 30% difference, respectively. And for ease of communication for the webinar, we can round these. So our threshold for a trivial or no effect is 60 fewer or more events or less. For going from a trivial to small effect, it's 61 events to 149 events. For a moderate effect, that would be 150 to 299. And then anything over 300, just rounding up to 295, would be considered a large effect. So again, about 6, 15, and 30% as our absolute effects. And now you can imagine we can apply this back to the forest plot. So here are thresholds, 60, 150, and 300 fewer events or more events per 1,000 people. Here again, we assume that the thresholds for benefits and harms are symmetrical. And we call that our effect estimate of 55 fewer people per 1,000 is here, corresponding to our risk ratio of 0.56, and the 95% confidence interval is 77 fewer to 22 fewer. So if we apply these thresholds, we can show that our threshold for going from a trivial to a small effect is 60. And here, for going from a small to moderate effect is 150 per 1,000. And if you do the calculation to present the threshold lines for the forest plots with the relative risks, you can see, for example, that a risk ratio of 0.09 is about 114 fewer events per 1,000 people. So all of the studies here are in the range of trivial or small effects. And likewise, our pooled effect here, 55 events fewer, does not reach our threshold of a small effect. So it is considered trivial to no effect. And here, for our determination of the effect size, we are using the point estimate. An example here of how the thresholds could be applied to forest plots in Cochrane systematic reviews to help communicate how we set the thresholds, but also then graphically, we get to see very quickly, for example, if the pooled estimate is crossing one of our decision thresholds for the imprecision judgment. And here, again, it's crossing one threshold, which you would apply for rating down for imprecision. A next application of the decision thresholds in our systematic reviews come to the communication of the findings. So already being applied in Cochrane systematic reviews, Grade Guidance 26 covers how to create informative statements to communicate the findings of systematic reviews of interventions, and included in the plain language summaries and in abstracts of Cochrane systematic reviews. Here, this is going to be a little bit small on the screen, but I'll show a zoomed in view. We have a rubric to make our conclusions about the effect we found for a given outcome in the systematic review that considers the size of the effect as well as the certainty of the evidence. So for each of the options in the rubric, we have suggested wording for describing our effect estimate from the systematic review for a given outcome. So here, for example, for low certainty of evidence, for a moderate size effect, we would say the intervention may reduce or increase the outcome, depending on the direction of the effect. For a small important effect, we would say the intervention may reduce or increase, depending on the effect direction, the outcome slightly. But now you see, how do we decide on what is a large, moderate, small, or trivial, or not important effect? And here we go back to setting those decision thresholds at the start of our systematic review process for each of our outcomes of interest that are prioritized for the review. Then presenting the results includes deciding on the size of the effect, the certainty of the evidence, and coming up with our informative statement that summarizes the result. And again, here the size of the effect would be as determined by the point estimate in relation to the thresholds we set. We apply the potential options from the rubric, determining what was our final certainty judgment, the size of the effect as based on our thresholds, and we write our conclusion. And likewise, this is already integrated into the grade per application, where for our summary of findings table, for the narrative statements under what happens, we're able to choose the size of the effect. And based on the certainty of evidence for the outcome, we have a generation of the narrative statement based on that rubric and the plain language. For the various qualifying words, we have the certainty rating. So high rating corresponds to is. Moderate certainty, likely or probably. Low certainty, may or evidence suggests. And for very low certainty, we say the evidence is very uncertain. But here for the effect size, we need to say whether there's a large reduction, a moderate or just a reduction or increase, a slight or small reduction or increase, or little to no effect. As an example, from a 2022 Cochrane systematic review on low carbohydrate diets versus balanced carbohydrate diets, we see here the summary of the effect estimates and the conclusions from the abstract, where the authors note that here in the subgroup of overweight and obese participants without type 2 diabetes, low carbohydrate weight reducing diets compared to balanced carbohydrate weight reducing diets probably result in little to no difference in change in body weight over 3 to 8.5 months. And this is based on that mean difference of 1.07 kilograms less in the intervention group. And here you see that the effect that is trivial or little to no difference is based on a threshold for a minimally important effect or a small important reduction. So in summary for today, and we can get to questions and comments, the certainty of evidence assessment relies on judgments about the confidence we have that the true value of an estimate falls within a specific range or above or below a certain threshold. The certainty is assessed according to the grade domains for rating the certainty of evidence, and we are able to set thresholds for the magnitude of benefits and harms, which importantly gives a reference value for the decision making. So as part of conducting a systematic review and rating the certainty of evidence, we do need to make judgments about what is considered a trivial, small, moderate, or large effect, or at least a small important effect, that being a benefit or a harm. And what setting decision thresholds as part of our reviews allows us to do is to have transparency for our certainty ratings. For users of the systematic review, they may apply different decision thresholds for whatever reason, for their context. Perhaps it's a different decision-making setting, or there may be supporting evidence that there are cultural differences where people would place different value on the outcomes. Although in general, from existing research evidence at least, typically outcome importance does not vary significantly between population groups, but there are case examples where different populations may set different values. So for that decision-making context, having transparency of how we came up with the thresholds and reporting what the thresholds were in the systematic review allows us to communicate that to the users of a systematic review. And likewise, applying the decision thresholds allows us to make conclusions about the size of the effects and to clearly communicate the findings to systematic review users using those standardized informative statements to summarize our results. So with that, I thank you for today and would take the remaining time for any questions and comments. Here's my contact information if you have any follow-up questions as well after the webinar. And I also invite you to subscribe to our Cochrane Canada McMaster Grade Center newsletter. There we post updates for our projects, including evidence synthesis guidelines, as well as methods projects, such as new grade guidance that our team members are involved in. Thank you.
Thank you, Wojtek, for that wonderful presentation. I was so excited to hear it, and I forgot to introduce myself. So just hi, everyone. My name is June, and I come from the Nottingham Nimble Great Center. And I can see, Wojtek, that your presentation has drummed up a lot of interest. We have a lot of questions in the chat. So we've got 10 minutes left, and we'll try to answer as many of these as possible. And at the start of it, Wojtek, there's a few people commented that they don't quite understand the concept of disutility. Could you say a few more words about that?
I'll try my best to answer some of the straightforward questions or quick answer questions in the chat. So disutility is simply 1 minus utility. So if a utility value is 0.85, that means we lose 0.15 of utility, which is our disutility value. And it's just so that we are not multiplying by a negative for the purpose of the calculation. So the online calculator for the thresholds based on research data, if you enter our utility value, it converts it to a disutility value by taking 1 minus utility.
Thank you. Moving on to the next question. So when defining empirical thresholds for binary outcomes in oncology specifically, such as a reduction in enlarged spleen, what utility value should be assigned to each health state? For example, presence versus absence of enlarged spleen. Should that utility reflect the health state itself, regardless of how the outcome was measured? It's a long question. You can see it in the chat at the very start of the...
Yeah, and it's cut off. Is there a... so when deciding on... so one of the challenges, where do we get the utility values from? And there we have studies such as time trade-off, for example, that present case scenarios to typically patients or decision makers to be able to calculate the utility of an outcome. And apologies, I see some of the questions, so I should have included a slide for a health utility value is a value from 0 to 1, where 0 represents the state of being dead and 1 represents the state of full health. So if we experience an adverse outcome, such as splenomegaly, so having a large spleen, with specific consequences for the person experiencing that outcome, we can consider that, they're no longer at full health, but they have some detriment to their health, and they would rate that outcome a given utility value. So in terms of which utility value should be assigned to each health state, for that, we use the description of the health outcome. So part of the Great Threshold study was describing a given outcome, especially if it doesn't have a common definition. So something like a runny nose, or a mild allergy such as a runny nose may be typically understood. But what we have applied in in studies where we generate utility values is a description of the health state. And 2, when we look for research evidence on health utility values, we try to most closely match up what would be the utility value reported in the literature to our outcome as prioritized by the systematic review authors, for example. So there, it's one of the challenges and why we often do check with, if it's in the context of decision-making like a guideline, we do check the decision thresholds. And that's why for systematic review authors as well, if choosing or deriving thresholds based on utility values, it will be important to note the source of the utility value because they often range from these studies as well. So in systematic reviews, we have some good examples of systematic reviews conducted as part of guidelines on patients' values, the values that patients place on outcomes and utility values reported, and there's often wide ranges. So I hope that answers the question. And if there are no utility values available, we often would apply approach 2 to ask decision makers specifically about what should the threshold be. or apply a more practical approach. I see the next question, what is baseline weight? So baseline weight was in that study, the control group event rate, for example, in that systematic review. So baseline weight, 100 kilos, for example, in that specific systematic review, and the control group event rate. And there, from that baseline rate, you might say, again, arbitrary, that a 5% reduction is your small important benefit, and 10% is a moderate, and 20% is large benefit. So hopefully that answers the questions around utility values.
Thanks, Wojtek. I can see what Li Wang and Peggy's question are similar. So it's about, are the thresholds supposed to be different across the outcomes? For example, those examples given on your TB slide.
So both on the, I'll show the slides again. So both on the TB slides and in the figure from the graphical representation, what this shows is that we can standardize on this figure. Oh, sorry, I'm going to go back here because this was quite a few slides ago. Here. So both here and here. So here, each of these thresholds, that's why there's no values here, is a different absolute effect. So while for trivial or no effect, for treatment failure, it was 30 from going from trivial to small effect. So you can imagine this line here for failure and recurrence is 30 here, fewer or more events. For death, this was not 30 because death is a more important outcome of this utility value of 1 or a utility value of 0. And this would be, for example, about half that rate, let's say 2% or 20 fewer events or more per 1,000 people. But presenting the figure in this way helps us communicate the estimates of effects in terms of their magnitude. So we see both here and in the figure here. Here it's just missing the point estimate, but assuming it's in the middle here, that this would be for moderate diarrhea. This is a trivial or no important effect. Likewise, for URTI, this is going to be trivial or no important effect. And then here, likewise, you can see for the point estimates where they lie. But the actual value here, the actual value set as an absolute effect for those thresholds is going to be different between outcomes based on the calculations off of the utility values or direct suggestions from the decision makers. Hope that answered that question.
Thank you. So let's pick up another question. How can we apply thresholds in conservative therapy trials studying the effect on pain, where, for instance, we have SMD? Would it be relative to comparator? Is a question.
Didn't catch the question.
Question from 2033. So how can we apply thresholds in conservative therapy trials, for example, studying the effect of where most of the outcomes are continuous, that you have SMD, and would it be relative to comparator?
Wouldn't it be exactly? So there, for SMDs, likewise, you have Cohen's effect sizes, but one of the considerations that has come up is when you are comparing in your systematic review to an active comparator or in a different context, would you set the thresholds differently? So this also gets at non-inferiority type questions where you set the threshold for what would be non-inferior. But in general, when we approach grade guidance, developing the grade guidance on the thresholds was the assumption that in general, the thresholds would apply across different contexts. So like a good example is, death as an outcome, whether it's death from one particular health condition or disease versus another, you would likely say that the outcome has equal importance in both contexts. But indeed, there may be some different contexts, such as conservative therapy trials, where you might set the thresholds differently. So that's where the decision-making context does need to be considered. I don't have a specific example offhand, but that may be one for consideration.
Thanks, Wojtek. I think we have 1 minute left. Could you answer this last one very quickly? So do you have to have all the 4 thresholds? Could you just set one? What if you don't have large threshold, you don't want to set, or you couldn't have a large effect threshold?
Yeah, so that's that first part about setting your target of certainty being beyond, above or below a certain threshold, so a single threshold. So you might set that threshold for that small important effect or your minimally important difference. And then your conclusion of the systematic review is that either that effect is beyond that threshold as a small important, or at least a small important effect, or below a threshold being a trivial and not important effect. So that's the other approach of setting a single threshold versus all 3 on the harms and benefits side.